There we go. So what does a good diagnosis look like? This is it. We need a full medical and family history. Um, there's comprehensive physical and neurological exams, full blood panel, looking for problems there, some type of imaging, be it a MRI, CT, or SPECT scan, neuropsychological testing, all the pen and paper tests that are done. And it's still, although diagnostic techniques have improved greatly, it's still by and large a diagnosis of exclusion. So they want to take away all those possible causes for the symptoms and before they arrive at a diagnosis. So take a look, all of you that work in the field, you'll recognize these symptoms. We know that it's short-term memory versus long-term memory. Long-term memory stays intact for a very long time, and you can look at these other areas and they all may or may not come into play with individuals who are experiencing early memory loss. As I've said, each person's progression, it's going to be unique to them. In general, however, memory disorders progress slowly over a long period of time in the absence of other comorbidities. So the focus that we have in Memory University is on how to live well with these illnesses. That said, as the disease progresses, individuals will need more help and more support. And so we ask that they graciously accept that help from their support network. These are the ways of treating the symptoms. You see on the left-hand side, all of the drugs that are used to treat Alzheimer's and other types of memory disorders. Over on the right side, you see a different class of drugs that are there to support people who are experiencing anxiety, depression. These conditions often coexist with the disease, and although we can't cure Alzheimer's, we certainly want to try to treat things like anxiety and depression, which can actually help people to feel more alert and function better. Agitation, sleep disturbances, all of those things are something that you can talk to the doctor about. And of course, we could do a whole lecture on the cholinesterase inhibitors and memantine and some of the newer drugs that are available for early stage, but you have the slides and you can reference these different treatments and learn more about them. We always stress the importance of clinical trials. I feel as though it's the only way we're ever going to cure this disease and find the answers that we need to help people is through the willingness of early stage individuals to participate in trials. And there are many opportunities. And here in Orange County, we have a number of opportunities, including UCI Mind. And here are some of the places that you can, or some of the websites where you can research clinical trials. There are pros and cons to each, and trials are not for everyone, but we certainly want to make our early stage folks aware of this, as well as some of the caregiver studies that are going on as well. So tips on living with the changes. You can just take a quick look at this slide. And it's pretty much about asking people, to try and adjust best they can to their new normal, to be flexible, to educate themselves, and to expand their network. And then an important caveat at the end of this slide is live each day to the fullest. So this is certainly the time to break out that bucket list and do the traveling or other things that, other goals that you want to meet. This is the time. This piece is about sharing the diagnosis. When we meet people early on in the disease, they're sometimes reluctant to tell others, but we try to give them the benefits of sharing the diagnosis with others, including the fact that it might be more stressful trying to hide the symptoms. And at the same time, people may have noticed changes in you and they are relieved to know why, and that it's actually a medical cause. So, and it's just an opportunity for your loved ones to be on your team and to offer help as needed. We want people living with this disease to articulate their own wishes. So we tell them, be proactive, not reactive. Do you want to make these decisions for yourself, or do you want others making decisions for you later? And so, of course, we're talking about, durable powers of attorney for healthcare and for finance, financial planning, all of those things that are so critical for people so that they can have a voice in decision making about end of life. And after all, that's what we all want. We all want to go through a process where we're able to write out and articulate our wishes and talk to our agents that we designate about our plans. So that's critical for anyone over the age of 18, but especially critical for dementia families. We get into the area of safety. So if we have people in the university or on our helpline who are living alone, we recognize that they need more help and increasing support, and that over time they will no longer be able to live on their own. So we help them to plan how to have a good quality of life and to bring others into the equation so that they are safe. We also talk about medications. And I think the bottom line here is we encourage people to partner with their significant others, and that people should take their meds together. There should be oversight. It's very easy to skip doses or to overtake medication, and you certainly don't want that to affect your treatment. Gun safety, as I mentioned early on, we have a gun safety expert who comes out and talks about legal ways to divest yourself of firearms in the house, because we know that dementia and guns don't mix. And then, of course, we have a driving expert who comes out and talks about being evaluated for safe driving when you're in the early stages of the illness. So just because you have MCI or early dementia, that doesn't necessarily mean that you can no longer drive. But with driving, we know that it's not a question of if, it's a question of when. So we want to educate people about how driving changes with the brain changes that are occurring in these illnesses, and we want them to plan for alternative transportation. Of course, we have resources for all of that. So we go through, how those brain changes specifically impact driving ability. And you see all of the bullets here on the screen that become apparent when people are still driving, or potentially can become apparent. And not to mention, I mean, kind of the bottom line with this is that people have the potential to hurt themselves or others if they're driving unsafely. And there's an issue of liability. So a lot of times, once we explain to people that if they have a diagnosis and they're in an accident, they will probably not be covered. I mean, I can say that with pretty much authority that they won't be covered. And so when you have Alzheimer's disease and you're in an accident, you risk losing everything. And then finally, you risk getting lost while you're behind the wheel, which can happen in a familiar place. It becomes very disconcerting and problematic, can be very traumatic. I have one client who got lost one time, and she finally made her way home, and she just marched inside and handed the keys off to her husband and said, "I'm never driving again." And we actually do have people that go through Memory University that, after hearing the lecture by the driving expert, will decide to give up the keys. So here's a few warning signs. You can take a look at that. A lot of dents and people scraping the side of their driveways getting out. I mean, people with the illness often have visual spatial problems, so they're not a good judge of distance. And so they may be tailgating, or they may get too close to other vehicles on the freeway. You see people having trouble with turns, particularly left-hand turns. Also trouble with those traffic lights. Maybe they're not seeing the colors quite the same way. And so, and maybe they're not reading the street signs. So there's lots of things that can go wrong. Driving is a very complex process. We multitask when we're driving, and we're paying attention to many things. And so when you have dementia, your ability to multitask is very diminished. So what we suggest is a driving evaluation that, of course, can be done at the DMV. It's supposed to be triggered by a physician report of dementia. That doesn't always happen. The physician doesn't always report it, or the DMV doesn't always follow through. And I understand that recently the DMV here in our area is waiving the written test for people over 70, I believe, altogether, because they're so backed up. So you can also pay for a professional driving assessment. And there are we have resources. I think there's more than two. You can call our helpline and get those resources. But one is at St. Jude. I think maybe some of the other area hospitals might have them too. And then we also are very aware of the driving center. And that's Debbie Ricker's program. And she's the expert who's written a book on dementia and driving. And she comes out and speaks to our folks at Memory University. So she's an occupational therapist. She will do an evaluation, a thorough, exhaustive evaluation of someone's driving, and let them know whether they're safe to drive or not. We touch on wandering. A lot of people don't wander ever, but over time, about 6 out of 10 folks with dementia will have one, if not multiple, wandering episodes. So, and it's not uncommon to feel disoriented with place and time sometimes.